No. Yeah, 1.1. Sorry.
It is 1.1?
It is 1.1.
Wow.
All right, we are back live. This is Senate Health and Welfare, March 8th, and we are going to look at the ALS Registry Bill S90 with our legislative counsel, Katie. Thank you for being here.
Yes,
I
nice to
call
see
you
you.
Lawyer McClin. I don't know how to
Katie
do
is
that.
perfect.
Okay.
Okay. So Katie McLean, Office of Legislative Counsel, and you should have draft 1.1 loaded on the website, the committee page. And this is a strike all amendment, but it looks very similar to the bill is introduced. There haven't been a whole lot of changes. So would you like me just to sort of highlight where the changes are or go through the whole bill?
Oh, well, I think an overview of what the whole bill is and then the changes specifically.
Okay.
10,000 feet and then.
Okay. So section 1 creates a new chapter entitled 18, the health title, on ALS and the creation of an ALS registry. So the first section is just a definition section. And then we have section 172, the establishment of the registry itself. And there's language that the commissioner, meaning the Commissioner of Health, is to establish a uniform statewide population-based ALS registry system for the collection of information determining the incidence of ALS and related data. And there's rule-making language that the commissioner is to adopt rules to affect the purposes of the chapter, including the data to be reported and the date at which the collection period begins. And subsection B, all cases of ALS diagnosed or treated in the state are to be reported to the Department of Health, a representative of the Department of Health authorized by the commissioner to compile data. And in subsection C, the commissioner is to establish a training program for the personnel of participating healthcare facilities and a quality control program for ALS data. And the commissioners collaborate in studies with clinicians and epidemiologists and publish reports on the results of these studies. The commissioner is to cooperate with the National Institutes of Health and the CDC in providing ALS incidence data. And then we move to section 173, participation in the program. Subsection A says that any healthcare facility diagnosing or providing treatment to patients with ALS shall report each case to the commissioner or the commissioner's representative in a format prescribed by the commissioner within 180 days of admission or diagnosis. And if the facility fails to report in a format prescribed by the commissioner's authorized representative can enter the facility and obtain the information and report it in the appropriate format. And in these cases, the facility is to reimburse the commissioner or representative for the cost of obtaining the information. In subsection B, there's language that any healthcare provider diagnosing or providing treatment to patients with ALS report each case to the commissioner or commissioner's representative within 180 days of diagnosis. And in subsection C, all healthcare facilities and healthcare providers who provide diagnostic or treatment services to patients with ALS shall report to the commissioner any further demographic, diagnostic, or treatment information requested by the commissioner concerning any person now or formerly receiving services. In addition, the commissioner or a representative is to have physical access to all records that would identify cases of ALS or would establish characteristics of ALS, treatment, medical status of any identified patient with ALS. What you'll notice is missing, there had been language about enforcement. I believe there was a penalty, and that language has been removed from this section. That brings us to the top of page 4, which is confidentiality language. In subdivision A1, all information reported pursuant to this chapter is exempt from public inspection under the Public Records Act. In subdivision 2A, all identifying information regarding an individual patient, healthcare provider, or healthcare facility contained in records of interviews or in reports, statements, or obtained by the commissioner or another person, agency, or organization acting with the commissioner in connection with with ALS morbidity and mortality studies is exempt from public inspection and copying under the PRA and shall be kept confidential and used only for the purposes of studying ALS. And we have language that nothing in this section is to prevent the commissioner from publishing statistical compilations of the data. And that this PRA exemption that's being created here is to continue in effect and is not repealed through the statutory process. Section 175 has to do with the disclosure of data. So this in subsection A gives the commissioner authority to enter into agreements and exchange confidential information with other existing ALS registries to obtain complete reports about Vermont residents. And so that Vermont can provide other states information about people diagnosed or treated in Vermont. In subsection B, the commissioner may furnish confidential information to other states, ALS registries, or health researchers in order to collaborate in a national ALS registry or to collaborate in ALS control and prevention research studies. However, before releasing confidential information, the commissioner is to obtain from any state registries, agencies, or researchers an agreement that all identifying information is confidential and privileged. And in the case of researchers, the commissioner shall also obtain evidence of approval of an academic committee for the protection of human subjects. And the last section in this new chapter that would be created is a liability section. So in subsection A, there's language that no action for damages arising from the disclosure of confidential or privileged information may be maintained against a person or employer or employee of any person who participates in the good faith reporting of ALS registry data or data with regard to ALS morbidity and mortality studies in accordance with the chapter. And similarly, in subsection B, a license of a healthcare facility or a healthcare provider cannot be denied, suspended, or revoked for the good faith disclosure of information pursuant to the chapter. And in subsection C, there's language that nothing in this section could be construed to apply to the unauthorized disclosure of confidential or privileged information if the disclosure is due to gross negligence or willful misconduct. So if you're acting in good faith, there's no liability. However, if you're acting with gross negligence or willful misconduct by releasing and disclosing confidential and privileged information, you're not protected. So everything I've just reviewed with you so far, that section 1, that takes effect July 1, 2023. And the reason for that is because there's a new section 2, and this section 2 requires the Department of Health to seek and apply for grants to fund the ALS registry. And as part of its fiscal year 2024 budget presentation, the department is to describe any grants applied for or awarded for this purpose, or other funding, other identified funding sources. So in essence, this gives the health department a year to identify grants and a funding source. So the registry itself wouldn't take effect for a full year until those funding sources or grants have been applied for and possibly awarded. And you'll see that those effective dates are reflected in section 3. So the effective date section in section 2, the grant application section, takes effect on July 1 of this year. And then the registry itself doesn't take effect until July 1, 2023.
Okay, so essentially the section that talked about enforcement, the fine section is gone.
Mm-hmm.
And remind us, there's already a place in statute that around professional regulation.
Yep, not professional regulations.
Okay.
It's in Title 18, there's a general penalty for any violation of any section within Title 18. I think it's 18 VSA Section 7. I will have to confirm that, but off the top of my head, that's what I think it is. And it's not a big penalty. I want to say it's $100 for being out of compliance, but I can double check that while you hear from your next witness.
Okay. All right, and then the grant piece for funding it, and I did reach out to Nolan, Katie and I reached out to Nolan on that, to help get that right. That's helpful. All right,
Are those the only two changes, removing the enforcement and adding the grant, and then
the effective date, so tiering the effective date and having the registry take effect July 1, 2023.
Senator Terenzini, do you want to add anything or ask a question?
Thank you, Senator Lyons. Can you hear me okay?
Yes.
Okay. Really, this is in my mind, this is a simple data collection bill of critical information that can be disseminated to the experts, the doctors and scientists, to try to determine if there are anything that can be taken away from it. I heard the week before last that this could offer false hope for those with ALS or with those who have ALS. This is not in any way a bill that we're trying to cure the disease, and I think it's important that I say that. I don't want to give false hope, and I know no one on this committee does. But could this be one step closer to us helping to find answers to this deadly disease? I think quite possibly, especially in Vermont. Last week, I had an opportunity to meet with Karen, who you're going to hear from, and another one of their representatives. And they have some exciting news that I hope Karen will mention quickly about how the ALS Association and scientists all over the world are fighting to make this a livable disease to some extent by the year of 2030. And so, if we're only eight years away from that being a possibility, that this could be somewhat of a livable disease, more like an MS, versus being 100% fatal as we know it is right now, I think all more reason for us to pass this simple bill. I know that the health department has had their reservations about it, but I think that this is an opportunity for us to stand boldly and pronounce that we understand the severity of this and that we are in a position where we can make a difference to those affected with this deadly disease.
Okay, thank you. Why don't we hear from Karen Hammer-Williamson, who is here, and then we can have a discussion. Karen, thank you for being here. Welcome. I think you know Senator Karen Terenzini, and I know you. Senator Lyons knows you. And then there are other folks around the table. Are Senator Cummings?
Yes. Hi.
Senator Hardy and Senator Hooker. So, and Aaron is sitting right behind me here, so he communicated with you. So why don't you, and I don't see testimony, written testimony from you on our webpage. Do we have it? We have it? Okay, good, thank you. All right. That's why Aaron is here, because he keeps me going straight.
if only saying refresh would actually really refresh us all.
Okay, thank you, here it is. Why don't you go ahead with your testimony, please?
Well, thank you very much,
Yep.
Senator. Thank you all for inviting the ALS Association to testify today, sharing our support for S90. I'm Karen Hammer-Williamson, as Senator mentioned, from Essex, Vermont, and I serve as the full-time Care Services Coordinator for the ALS Association Northern New England chapter, serving the nearly 40 individuals with ALS living in Vermont and their family caregivers, as well as a dozen or more New York residents who attend the UVM ALS clinic. I previously served and have met many of you as the first supervisor of residential alternatives in long-term care for the Vermont Department of Disabilities, Aging, and Independent Living, and also worked as the former Champlain Valley Area Health Education Center, supporting primary care, particularly to underserved populations in Vermont. For the benefit of anyone listening who is new to ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is an always fatal neurodegenerative disease in which a person's brain loses connection with the muscles, and people with ALS lose their ability to walk, talk, eat, and eventually to breathe. ALS usually strikes people between the ages of 40 through 70, but it can strike anyone at any time. And with no known cure and limited treatment options, the life expectancy after diagnosis is 2 to 5 years. The annual cost for an ALS patient is estimated at $250,000. The ALS Association's vision, as you might imagine, is a world without ALS, and our mission is to discourage treatments and a cure for ALS, and to serve, advocate for, and empower people affected by ALS to live their lives to the fullest. We have set an ambitious goal to make ALS a livable condition by 2030. The ALS Association was founded when smaller organizations established by people living with ALS came together in order to have greater impact. It is now the largest private funder of ALS research worldwide. Our efforts have led to some of the most promising and significant advances in ALS research. The association also provides a wide range of care services to people living with ALS in every state and supports multidisciplinary care, or MDC, in ALS clinics nationwide, including the highest standard of clinic care, a Center of Excellence designation that has been earned by the clinics at UVM and Dartmouth-Hitchcock. Our advocacy partnership with individuals living with ALS has boosted federal and state spending. The 2021 federal research investments in ALS include $110 million at the National Institutes of Health, $40 million by the Department of Defense, and $10 million by the Centers for Disease Control and Prevention for the National ALS Registry and Biorepository. The bill to create the National ALS Registry and Biorepository was signed into law in 2008. And I mentioned their funding levels. It includes data from existing national databases such as Medicare and the VA, as well as information provided directly by people with ALS who choose to participate. Researchers can use the data to look for disease pattern changes over time and to try to identify common risk factors. The registry also funds 21 academic institutions to identify, examine, and evaluate potential risk factors for ALS. These grants are focused on environmental exposures to heavy metals and persistent organic pollutants, genetics, identification of biomarkers, and occupational exposures. It further funds selected state and metropolitan area ALS surveillance projects because of concerns that data on minority groups might be missing from the ALS registry. Lastly, the registry includes a biorepository that collects blood, urine, hair, and fingernail clipping specimens from people living with ALS, and post-mortem donations of brain, spinal cord, cerebral spinal fluid, and muscle, skin, and bone. However, the National Registry has not been able to provide data that can be used by researchers on a state-by-state basis. This is because of federal regulations preventing the release of state-specific data, patient privacy regulations, and ALS's status as a non-reportable, non-notifiable disease. For these reasons, the ALS Association supports the development of a Vermont ALS registry. Dr. Rup Tandon, Director of ALS Clinical and Research Center of Excellence at UVM, estimates that 20% of people living with ALS are unaccounted for and therefore unable to seek the benefits of being evaluated and treated in a specialized clinic. His expertise and compassion for people living with ALS speaks for itself. I'll mention that he recently retired from his full-time work at the university. His leadership of the UVM ALS clinic continues as a passion project, and we're very grateful, as it would be a great loss. An ALS registry would support research efforts and could help identify people who would benefit from care. The Vermont registry could build on the model of the Massachusetts ALS registry, which precedes creation of the National ALS registry in 2008. In 2002, Massachusetts was one of 7 states awarded funds by the U.S. Centers for Disease Control and Prevention to track health conditions thought to be impacted by the environment. The statewide registry, initially supported by the CDC funds but now supported with state funds, was established in 2003 and called for more research into the causes of ALS. Today, the registry collects patient demographics, clinical symptoms, and lab data, diagnosis, and treatment. State funding for 2021 is estimated to be just over $290,000, and all documents are available on the Massachusetts Bureau of Environmental Health website. The National ALS Registry is working with the state of Massachusetts to compare their reported ALS cases to registry data. And I didn't want to pass up a chance to share a little bit of information about people in Vermont. All association care services are designed to supplement public and private insurance and care systems. They're delivered free of charge to the nearly 40 and sometimes more Vermonters living with ALS and their family, and follow up on recommendations made by multidisciplinary clinic teams and other providers such as home health agencies and primary care. In addition to UVM and Dartmouth, Vermonters consult MDCs at the VA, Massachusetts General Hospital, and St. Peter's Hospital in New York. Equally important, we help individuals and families with confidential support groups, workshops for newly diagnosed individuals, learning labs for family caregivers, durable medical equipment loans, financial grants, and referrals to other funding sources that, whilst generous, do not meet patient financial need, especially for working single people and child-rearing families. Peer advocacy opportunities, provider outreach, bereavement supports, an annual symposium, and a large array of evidence-based education opportunities from our national staff. And somehow in the midst of that, I left out home visits, which I've been conducting over Zoom since the pandemic. The association appreciates that whenever possible, Vermont has built its public policy and programs to serve Vermonters at comparable financial and functional need, regardless of diagnosis or type of disability, an all boats float approach. We hope to have an opportunity to return in the future with Vermonters with ALS to share with you where they are struggling, especially given the high cost of this illness, time urgency, and opportunities to prevent and reduce harms and costs. They are advocating this week for federal funding for the new Act for ALS federal legislation signed into law in December, which can provide great improvements but will not address needs that depend upon state programs and initiatives. Thank you for this opportunity to testify in support of S90 and for your committee's interest in Vermonters living with ALS and their families. I'm glad to answer any questions you have.
Thank you very much, Karen. It's very helpful. This is more local information that is supports some of the work that we think might be needed. Questions for Karen from the ALS Association of Northern New England. So the number of patients that you work with in the Vermont area and then the local New York area. So you said 40 patients in Vermont?
About 40 from Vermont and another dozen who attend UVM ALS clinic. The 40 from Vermont attend all the different ALS clinics I mentioned. So you can begin to see how getting a picture of what is going on in Vermont could be complicated for any single researcher when people are attending one or more of 5 different clinics.
Absolutely. Okay, Senator Hooker has a question.
Thank you, Karen. You also mentioned that 20% of the patients are really unknown, so that 40 that you're talking about would be approximately 80% of the number of patients in the state.
By Dr. Tandon's estimate, which is an estimate for a larger region, the Vermont number looks a bit lower, around 14%.
Senator Terenzini.
Yeah, if I could ask Karen. Karen, do you know sort of what percentage of those in Vermont with ALS go to UVM versus go seek treatment at Dartmouth?
Oh, I'd have to recalculate my percentages because I did it with respect to all the clinics. I would say maybe around around 50 to 60% go to UVM. It really tends to be geographically driven over time, and it can change over time. Many people get their second opinions at Mass General. Some continue there because certain research had been taking place there that was not available in Vermont. But in partnership with the Healy Center at Mass General, some of that research and related visits can be accessed now through UVM and Dartmouth. So it really depends on the person and how they're using care services and practitioners. The Healy Center also has uh, assistance in the area of communication and augmented communication that's helpful to many people. In the southern part of the state, there's quite a shortage of those services, so those folks also tend to go to Mass General quite a bit.
Thank you.
Mm-hmm.
Senator Hooker.
Yeah, with regard to the services, you say that the services are designed to supplement private and public insurance and care systems. Who provides those services?
The care services of the association, I coordinate them. We've been working with Yankee Medical, who has housed our durable equipment medical loan program. That will obviously be changing. I and the other care services coordinators facilitate support groups. Most of them are a peer support model and an education model that we do directly. A few support groups are facilitated by clinical staff, a clinical social worker in Maine who specializes in mindfulness and ALS, another retired hospice social worker who does a clinical group in bereavement for people who need more than peer support around bereavement. And then education happens at different levels by appropriate providers. Obviously, long-term care is by home health. There's only one nursing home, the Pines in Rutland, that will serve people on invasive ventilation. So people who need that service go there. Veterans who need long-term assisted living or residential care tend to be down at the VA in the southern part of the state, the Veterans Home. The list goes on. So it's people with ALS are using the full system of care. There will be an initiative by UVM ALS Clinic to help home health agencies identify lead nurses in ALS care and to receive some additional specialized training. And we try to make sure that everyone knows that they can access the clinic staff of either Dartmouth, UVM, or Mass General or St. Peter's between clinic visits. But that could be better utilized, so that project will work. And there's been a telehealth initiative that started before COVID to help people overcome travel distances that over time can become a barrier to multidisciplinary care.
Thank you.
Thank you. Any other questions for Karen? Okay, thank you so much for making yourself available this morning. It's been very informative. Appreciate it.
Thank you so much.
Yeah. So I think Nolan, Senator Hardy.
I just wondered if we could talk, are we gonna talk about the bill and the language? Okay, go ahead. If
Yeah.
you wanted to have Nolan.
Yeah, I was just gonna ask Nolan if you had any comments that you wanted to make about the grants piece or the funding piece. Is there, what would we see for a fiscal note, I guess, question.
For the record, Noel Langwell, the Joint Fiscal Office. So the bill doesn't have the registry effective till fiscal year 24, right? Because it's July 1, 23.
Yeah.
So there would not need an appropriation bill this year, but you would likely need an appropriation next year to the extent that the health department is unable to find grants.
Okay.
And the range of numbers I've heard range between 75 and 100,000, because there would be some PT costs. And then they would need a 0.25 to 0.5 FTE. And that would need appropriation. As an aside, 89% of the health department's budget are federal grants.
Right.
The federal grants are very specific to what they're doing. And much of the other 11% general fund is used for match or maintenance of effort pieces to maintain the other 89%. So there's not a lot of flexibility in their budget to accommodate that. So I would probably say in a fiscal note that there would be resources or appropriation needed for fiscal year 24 to the extent that federal grants or other grants are not, the health department's unable to attain those grants.
I have a question. Is it ever the case, the ALS organization that we just heard from has a whole bunch of grants that they send out, but we can't answer for them, but is it ever the case that our department would apply for a grant from a private organization?
Possibly.
So, you know, I see it.
Whether again from foundations or
Yeah.
whatever, I don't know the answer to
Okay.
that.
So there's an opportunity there then for some funding source.
Yeah, I think the language is vague. It just says apply for grants, right? It doesn't say private or public, right?
They can do it, yeah.
So I don't know what their rules are, but
Okay. Okay, any questions on that? Because I know that was the big barrier that DOH had brought up. So we want to think creatively about how to help. All right. Good, okay. All right, let's just look to the next, we got about 8 minutes left. Senator Hardy?
Yeah, I had a question for Kate.
Yeah, we're gonna,
It's awkward, I'm like not sure how this works anymore. I'm like,
and here she is.
little box.
Yeah, go ahead.
So I was just looking at the statute on the cancer registry.
Okay.
To see if, it seems like the ALS in S90 is fairly similar. There are a couple of differences, but the language that establishes the cancer registry versus the ALS registry. Sorry, this was a surprise question.
Yeah, no, that's okay. I'm pulling up the language.
Yeah, it's chapter 4 of Title 18.
Right, the sections do track pretty closely to the sections in the bill in front of you. I need to look a little bit more closely within each section to see how the language tracks, but in terms of topics covered, yes,
Yeah, it looks like, it looks pretty similar. I guess well, first thank you, Josh, or Senator Terenzini, for your work on this. I guess I'm not seeing some of the things in the bill that we've talked about as a committee before. It's pretty much the same bill. So I was expecting more changes in terms of our discussions about, there's nothing in the bill about care of the patients. It's just, and trying to link patients to healthcare options. It's still just a state registry for a very, very, very small, population that will produce data that's not scientifically viable because it's such a small sample size. So I am incredibly sympathetic to the families and people who are impacted by this disease. It's a horrible disease. I'm just wanting to make sure that if we're going to do something, we do something that's going to have an impact. And I think that this is so narrow and our state is so small that if we create this registry, it won't have the impact that people think it will have. And so that's why I was more interested in either creating language that would lead toward a more regional registry that would have a broader impact and broader data, or a registry that is a broader, like the cancer registry is all cancer. So a registry for all neurodegenerative diseases, ALS being one of them, so that we would actually collect a broader sample of data. If we're gonna go through the whole process of doing this, then it seems to me that either broadening it in either direction is better. And also making it more of a connection to care options and services for patients and families impacted by ALS.
Okay. Senator Terenzini.
Thank you, Senator Lyons. May I respond to Senator Hardy's comments?
Sure, we're in discussion mode.
Yeah. So I think your comments are rather valid, Senator Hardy. I think when I looked at this again last week, and Senator Lyons and I spoke a couple times, and I met with the folks from ALS, it simply came down to what you're talking about makes a lot of sense. It came down to time for us in the Senate to try to get this bill voted out. In my opinion, anyway, this is a good foundation to send over to the other chamber, and then I think we could give some of our ideas that maybe we simply ran out of time to discuss or research. Maybe they can pick up and make this bill better after we voted out of committee if we have a positive vote.
That's totally, may I respond? I don't know how this works now in person.
We're in discussion mode. We're in discussion mode.
I totally understand the timing issue and the potential to have the House improve on it. I mean, I would be more comfortable if we simply just changed it from specific to ALS to more broad of neurodegenerative diseases, or whatever the appropriate term is, and created the sort of equivalent to the cancer registry, and then send that to the House for them to and have everything else the same. And it just, with 40 people, we're not going to get the kind of data that we're interested in. And
40 plus 12.
40%.
Well, but we don't know, you know.
And that's a year. That's a year, remember.
But I guess I would rather see this be broadened either but regionally, or sort of the whole, for lack of, I don't know what the medical word is, the family of diseases. Like,
well, you know, here's what I think, you know, that's a good point to make. I think the cancer registry might have even started narrower with breast cancer. So we'd have to go back historically to see how all these things have evolved. But there is a section in the bill that does talk about reaching out to broaden it to more regional. So I think that's a good thing. We did hear from the ALS folks that they have a strong system of support for patients. They just don't know where all the patients are. And then by collecting the information from this disease, that really people don't live long enough to get good data. That's one of the problems. You know, they live 2 years, 3 years, but you can't follow them longitudinally. It's such a short period of time. So every patient you don't have to evaluate and to look at is a lot of lost data. So there's some benefit to having that information. And we do know that there's now a whole MS organization, and there's a lot of stuff that's going on with other types of neurological disorders that may be slightly different. We don't even know the beginnings of ALS, but we do know a lot about what's happening with things like MS. So this is an opportunity to just get the train started down the track. I kind of disagree about, you know, maybe the House will improve it. Well, maybe they will. I know the Department of Health suggested that they put out an HAN, a Health Action Network alert system, where people report patients with these symptoms. But that's not a registry. And so it's not, it doesn't have the authority that a statute would have. So, I think we should go forward and collect the data that we can get. The next step is, I think, how do we look at the etiology? What's the epidemiology of this thing? We don't know. So anyway, keep going.
Can I make a suggestion?
Yeah, that's okay.
I mean, I don't want to vote against the bill. I'm supportive of trying to do what we can to help. I just don't know that this bill will help. And so I'm trying to figure out ways that we could set it up to be more of a success. So how about in section 2 that was just added, the grant section, that we turn that into similar to, we had a report section in the Alzheimer's bill that required them to come back to us next year. Katie, I think you drafted that, about how much it would cost to fund something. So we require them to come back and report to us. And in that report, we keep the first section with the delayed effective date. And in that report, we request that we require them to report on how to recommendations for the potential of expanding it to a broader disease category, or expanding it to a regional data. So they can look into that in the off session and come back, and they would have to report to us on funding sources.
I would do that if we kept section 2 as it is and added another section of that would ask for that report. Because I think we have heard how much it costs. We've heard what the issue is. We know that there are people who have been affected by ALS, who are working with ALS patients, and others who, the researchers themselves, who think, it's time to collect this. We could add that in. I think that's a good thing to do, would be to add in the report back. And remember, the report will be coming back at the same time that they're trying to find money, if they do.
Right.
Senator Cummings.
Well, that's my question. Given the Department of Health has a fairly full plate, do they have staff to start writing grants?
That's how they live. And there may be, listen, that's the other reason I brought up the ALS group, because now groups will be seeing this as an opportunity to suggest we have a grants program, and we would be happy to respond to they could send an RFP out.
Yeah, I mean, I guess I am actually uncomfortable that this is being driven by a few researchers who are wanting to create a public registry for their own personal research. Now, obviously, their research is supposed to impact, the health and well-being of other people. I get that. I totally get that. But there are other diseases that have a broader impact that are also incurable. So
that's true. But
they want a registry.
You've got the Lupus Foundation. We could get a lupus registry going. We could get all kinds of different ones. This came from patients' families. This request has come from families who are just needing to understand how many people are out there and where are they, and so on. So we're going overtime. So I'm interested in getting this bill finalized and there's a little bit of timing about it, but I do think that this bill has been around for a while, and we hear the same pushback. So maybe it's time to take a step forward. That's all.
Well, I think it's legitimate pushback, and that's why we keep hearing it, because it's so narrow. It's so driven by a few researchers. I
hear you say that, but I feel it's driven by families in my district. So I hear from them all the time, and I know some of the people who are having these difficulties. But anyway, so Katie, there we are.
I don't know where we are.
Section here.